My name is Arvind. I'm one of the intensivists at Nepean. I run this program called Learning Ultrasound in Critical Care, which is a long-term competency program over 3 to 6 months. Over 3 to 6 months, which is for basic trainees. So this is not for advanced level. If any of you knows basic trainees who are extremely committed, this is free of charge. It's online mentoring where they scan one patient every, about 10 scans every 15 days, and then they meet up with an assigned supervisor. I do research on this. This is my PhD topic. So if anyone wants to get on board with the research as well, there could be possible collaborations and authorships and so on. So you can contact me. Abdominal ultrasound. A lot of people are, Okay, I've just minimized the teams. I can't see any of you. So if you want to tell something, I can't see your chat. I can't see your icons or emojis. So just unmute and speak up. Okay. Now, abdominal ultrasound is something that most people don't do very often. But in my opinion, it's probably the easiest ultrasound to learn. And the reason for that is all of us know about the anatomy of the abdomen. Every single, we see this day in and day out with the CT scans of the abdomen. And therefore, unlike the internal anatomy of the heart, we actually know that the liver is a large organ in the right upper quadrant. Inferior, and one very important thing before I even start, I'd like you to avoid using words like above, below, etc. Make sure that you use anatomical terms when you're describing ultrasound, whether it is cardiac ultrasound, any ultrasound. Make sure that you use the words superior, inferior, medial, lateral, and if you want to describe something, point towards the right shoulder, left hip, etc. This simple change in how you approach things will suddenly make it so much easier for you to to modify a particular image that you get in order to rectify it. Okay, whichever ultrasound it is. So going back to the abdominal, going back to this, we have the liver is a huge organ on the right side of the abdomen, just under the diaphragm. Okay. Inferior to the liver, you have the right kidney. And on the other side, which is the left side, the same, you have the spleen and the kidney. And the left kidney is superior to the right kidney, the level of the right kidney, purely because the spleen is smaller than the liver. Okay. Then you have coming from the somewhere near the middle of the liver, the hilum of the liver, the porta hepatic, you have the gallbladder. And then adjacent to the gallbladder, you will have the pancreas, but that's more posterior, on a more posterior plane. Okay, it's in the midline, but it's far more posterior or deep when you're scanning from anterior to posterior. And then you have the bowels all through, starting from the stomach, the first part of the duodenum, and then you have all the small bowel and the large gut. Every one of us knows this extremely well. I haven't written here, I haven't drawn here the other things, namely the ureters coming from the kidneys. I haven't drawn the urinary bladder. I haven't drawn the uterus in women. I haven't drawn the ovaries in women. So these things, all of us know this very well. The reason I haven't drawn those things is mainly because I think the genitourinary tract is something we are interested in as clinicians, as critical care physicians. However, we don't often look at the the adnexal system in the pelvis, but there's no reason why you cannot do it. It's so easy, so intuitive. Okay. Now, then the other things you have. Now, this is the basic architecture. Once you remove the bowels from the equation, then you have the big blood vessels, and you have the aorta on the left side. So the aorta is here, and the IVC is on the right side. Okay, and these are two longitudinal. They are straight tubes or cylinders going from the heart all the way down to where they bifurcate into the iliac veins or arteries. Then you have the portal venous system. So starting from the spleen here, they go all the way, and it goes superior mesenteric. You have the splenic vein, the superior mesenteric vein joins. That becomes the portal vein, and that branches off. Then you have the tubes inside the liver, which is the bile ducts and so on, and you have the bile duct joining into the gallbladder. You have the pancreatic duct. Sorry, you have the pancreatic duct joining into that confluence. So we all know this anatomy, and if you think about it, before you started doing cardiac echo, if I asked you about the internal anatomy of the heart, and even now, even after doing cardiac echo, the three-dimensional visualization of the heart is something that we haven't learned in MBBS. We haven't really conceptualized it or visualized it. And therefore, it's actually extremely difficult for us to understand various parts of the interatrial septum, for example, why the heart doesn't actually have a posterior wall, it only has an anterior wall, etc. On the other hand, the abdomen is something that we deal with every single day, and this anatomy is intuitive, and ultrasound and CT scan, for that matter, any imaging, is all about the anatomy. And for that reason, in my opinion, ultrasound of the abdomen is a skill that is super easy to learn by any clinician who is well versed in the anatomy. Okay, any questions so far? Any questions so far? Okay, right. Right. I'm just going to stop rehearsing the timings. Give me a minute. There's the slides updated. This is actually part of a pre-recorded slide. Okay, no, that's fine. I'll just. Now, let's go to the gallbladder ultrasound. Okay. Gallbladder anatomy. The gallbladder anatomy it's in the right hypochondrium. Okay. So it's here. If you divide the abdomen into various quadrants, you have, this is the umbilicus will be here. Sorry? Oh, sorry. Can you see it now?
Yeah.
Okay. So this is you divide the abdomen, as we know, into various quadrants. So this here is the right hypochondrium. The gallbladder is going to be somewhere there. Because it's a mobile body. It has a fixed neck, which is attached to the porta hepatis, somewhere in the region of the porta hepatis. And then the actual body of the gallbladder is mobile. And depending on whether it is empty or full, it's going to be affected variably by gravity. And therefore, the position can be anywhere under the right costal margin. So it could be anywhere along here. Okay. When you're scanning, therefore, what do? You just have to pick a spot somewhere here. Okay. And you can go anywhere in this direction, anywhere in this direction. And if you don't get any anechoic space, you can go up or down. You just search somewhere in this area, and that's where you're going to find the gallbladder. Unless the patient has had a cholecystectomy, you're bound to find the gallbladder. Okay, it is super easy. Now, just like with in general, when you're doing ultrasound, the dictum is identify two structures that you can recognize. Okay, you have to identify two structures, and once you identify two structures, and you know the anatomy of those two structures, the relationship of the two structures, that means that you now have the bearing to go superior or inferior or medial or lateral or oblique. Okay, so what are the common structures that you will encounter when you are scanning this particular area? Okay, the first thing that you have to get is the liver. Okay, the liver is this big structure That is, unless the patient is cirrhotic, the liver is going to be at least 10 to 12 centimeters in span. So that's somewhere here. Okay. So get the liver. And this is something that is almost, it is impossible for you to miss getting the liver. Okay. If you do not get the liver at all, what could be the reasons? The reasons might be that you are high up in the thorax, which means that you're going to get lung markings, or you're going to be somewhere inferior, somewhere here, okay? Or you're going to have crowded rib spaces which are causing acoustic shadows. So each of these will have its own characteristic pattern. If you're going to have an A-line pattern or a lung marking pattern, then you have to move inferiorly. On the other hand, if you're inferior to the liver, you are going to see those some kind of an abdominal structure. You'll either be able to see the kidney, or you'll be able to see loops of bowel, or you can see fluid-filled loops in the bowel, or sometimes you can actually see, and you can see the gut artifacts. That means you have to go superiorly, or you might be somewhere in the laterally, so you might have to go superolaterally. So it is, you keep the probe somewhere in the region of the liver, search for the liver, and you identify the liver as a mixed echoic structure which has a lot of fluid-filled spaces. Where is it? I don't think I have a picture of the liver on ultrasound itself. I'm sorry. But it is super easy to get the liver. Okay. Once you get the liver, then just a second, I'm just going to erase all this. Sorry. Can you still see my screen? Anyone not able to see my screen? Okay. Now, once you get the liver, you're either going to be here or here or here or here or here or here. Okay. Then what? What you do is, suppose you only see the liver and you don't yet see the second structure, then your job is to slide the probe in any one direction to look for that second structure. What I often do is I go inferiorly in order to get the kidneys. And once I know that I have gone in, once I can get the liver and the kidney together, I know where exactly I am in the abdomen, what the anatomy is. Once I have that, I know that all I have to do now is to start scanning in a direction towards the midline in an oblique fashion along the costal margin, and I should be able to find the gallbladder. Okay. Okay. Now, the gallbladder itself, how is the gallbladder? The gallbladder is, it has the shape of a partially inflated balloon. Okay. The size of the gallbladder is extremely variable depending on whether it is full or empty. The gallbladder empties itself at the end of a meal when you eat, and therefore it ends up releasing its bile. In a fasting state, it is full. Therefore, the size of the gallbladder can vary anywhere from 2 centimeters, 3 or 4 centimeters to almost about 8 or 9 centimeters in its longitudinal axis. And in the transverse axis, it can be anywhere between 2 to 3 centimeters or 2 to 4 centimeters. Okay. Once you identify some part of the gallbladder, okay, once you identify any part of the gallbladder, the next thing you want to do is to make sure that you identify the fixed part of the gallbladder, which is the neck of the gallbladder, which is here. Okay. So the neck of the gallbladder is identified by this fixed anatomical relationship. It is attached to the main lobar fissure of the liver. So if this is the liver is split into the left and the right by a lobar fissure, and the gallbladder is essentially, it is attached somewhere here. Okay. Now, in that same lobar fissure, you have the porta hepatis, and that means the portal vein. So the fixed relationship of the gallbladder. Remember, I told you that this particular part of the gallbladder has a variable anatomical relationship, and that's because the body can flop around, and depending on whether it is empty or whether, and it's affected by gravity. But this part of the gallbladder, which is the neck of the gallbladder, which is attached to the porta hepatis, the region of the porta hepatis, and the portal vein, this is constant, and you have to try and identify that. Okay, and this is how it will look like. You will have the gallbladder, and this will be the neck of the gallbladder. Okay, this is the portal vein. This is the major interlobar fissure of the liver. And somewhere here, sorry, this is the CBD. This is the interlobar fissure of the liver connecting the two. This thing here is the CBD, and this is the hepatic artery in its short axis. And in this particular thing, the gallbladder is in its long axis, whereas the portal vein is in its short axis. The hepatic artery is in its short axis. And the CBD will be somewhere in the middle. It's a little bit oblique. So this is called the exclamation mark sign. And this is something that you always have to try and identify. And the way you will identify that is first find the liver. So this thing here, this is the liver here. Okay. Once you get the liver, then you slide the probe either superiorly. Sorry, I generally slide the probe inferiorly to get the kidney. Once I know that, then you can start scanning somewhere along this direction, and you get some part of the gallbladder, and then you start rotating the probe in order to get this, in order to get the exclamation mark. Okay. Any questions so far? Any doubts about it so far? I'll pause for a minute. Anything so far? Okay. Right. Now, if you rotate the probe by 90 degrees and get the gallbladder in its short axis, which is the transverse axis, a number of the other structures will end up going longer. And here you have something called the Mickey Mouse sign, wherein you have the portal vein in its portal vein, which is slightly posterior, and you have the hepatic artery, which is medial to the portal vein, and the common bile duct, which is slightly lateral to the portal vein, and you'll have this. This is called the Mickey Mouse sign. I have to confess that I don't do this very often. For me, the longitudinal axis, the long axis, and the exclamation mark is what I really aim for. But the short axis, I'll tell you when I use the short axis in a minute. Okay, so once again, recouping the technique, the patient's position can be anything. Okay, in very difficult cases, I sometimes put them in the left lateral position, but otherwise, in general, in critically ill patients, I always try to do the case in the same position as the patient is already in. I try not to move them just for convenience. Okay. Even if it's cardiac echo, for example. Then once you have the patient the way you hold the probe is in the longitudinal position. So the initial probe position, and remember this word initial, because the final probe position is always, the initial probe position is always blind. This is regardless of what ultrasound you do, whether it is cardiac echo or any other things. The first time you keep the probe, you just keep it somewhere in the region of the structure of interest, and it's blind. You don't know what's going to come. The final probe position, on the other hand, is a considered manipulation of the probe, depending on whether you have, depending on what you see. So the initial probe position, I generally keep it longitudinal, somewhere along the costal margin. So these are the ribs. Okay, this is the sternum here. So somewhere here, I keep the probe under the right costal margin. And sometimes you might need to keep it intercostally if the patient has a distended abdomen, etc., and the abdominal structures are going subcostally. Okay, so you keep it somewhere along the right costal margin, and you then, once you've got the liver, once you've identified where you are with the kidney and all that, then what you do is you start sliding the probe gradually towards the midline, and you sweep along the costal margin, along somewhere here, until you see some part of the gallbladder, and then you have to rotate the probe. Typically, you rotate the probe anti-clockwise if the probe marker is facing the 12 o'clock position, and if you're using the curvilinear abdominal probe, then if you rotate anti-clockwise, it means that the structures on the screen, this will be superior and this will be inferior. Okay. Now, there's no reason why you can't rotate clockwise at all, because finally you're just going to get an upside down image, but that's not a problem. So I rotate the probe anti-clockwise to preserve the anatomical relationship, and then you find the exclamation mark. It is extremely important to get this sign because you have other structures that are anechoic. The IVC is anechoic. The bowel loops, depending on the patient, if you have somebody with bowel obstruction, a bowel loop, especially the third part of the duodenum, the second part of the duodenum can actually be, you can actually mistake that for the gallbladder. And that will also have, depending on whether, if it has fluid, it'll be anechoic here with a very thick gallbladder wall. And I personally, in my first 5 or 10 scans, I actually mistook a normal duodenum to be a gallbladder with thickened wall. Okay, so that's why you have to get this exclamation mark sign in order to get the anatomical relationship. Okay. What else can you do? Once you get the 2D, then you can put some color Doppler in order to locate some of the vessels, and then you can rotate the probe in the transverse or oblique planes. But what you have to do initially is you have to get the gallbladder in its longest axis. If this is the longest part of the gallbladder, this is an oblique axis. This is a completely transverse axis. So depending on what you get, you have to always rotate the probe to get the longest dimension of the length of the gallbladder, and that means, and that's usually the place where you will get the exclamation mark as well. What happens if you cannot see the gallbladder at all? Okay, obviously the patient could have had a cholecystectomy, so you might need to get corroborated history. What you can try the left lateral position. If your patient is able to take a deep inspiratory hold, which a lot of our patients are unable to, then you can try that. And you can stop feeds or keep the patient fasting and come back in an hour or so that the gallbladder becomes a little bit bigger. Rib shadows are often in the way. And if you have that, then you just have to find if this is a very narrow window and your curvilinear probe is causing lots of acoustic artifacts coming from the ribs, you have to try and look at the window in between to locate the gallbladder. And alternate thing is you can choose a smaller probe with a smaller footprint, like a phased array convex probe, a cardiac echo probe. Okay. Taking a deep breath will push the gallbladder inferiorly, hopefully inferior to the costal margin, and that can overcome the acoustic shadow coming from the ribs. Now, what do we want to know? The specific things that we want to know, the main things as acute care physicians that we want to know are, does the patient have cholecystitis? And in patients with cholestatic liver enzymes or patients with jaundice, you want to know whether the cause of that is biliary obstruction. Another thing could be, if you have pancreatitis, you want to know whether it is biliary pancreatitis. So you want to know whether there is biliary obstruction. These are the two indications for point of care biliary ultrasound. In fact, not even point of care. Most of the time when you do critical care ultrasound, this is what they're asking. The signs of cholecystitis. Now, can I ask you now? Okay, can you all unmute? And what are the signs of cholecystitis?
Pericholecystic fluid.
Sorry, pericholecystic fluid. Okay, so you're saying pericholecystic fluid because cholecystitis is inflammation of the gallbladder. Any inflammation is going to cause fluid around the gallbladder, fluid around that structure. So inflammatory edema or pericholecystic fluid, which is water around the gallbladder. Now, before the edema goes out of the gallbladder to cause pericholecystic fluid, what will happen? What is the one step before that?
Sludge in the gallbladder.
No, not necessary. That's because of stasis. I'm asking for inflammation of the gallbladder. What is the step when you have inflammatory fluid causing pericholecystic fluid, a step before that, before the fluid escapes out of the gallbladder and goes around the gallbladder, something else will happen. It will happen to the gallbladder itself.
Thickening of the gallbladder wall.
Thickening of the gallbladder, and that is again due to edema. Okay, right. What are the other signs of cholecystitis? Or rather, sorry, what kind of patients develop cholecystitis? What is the risk factor?
Gallstones.
So typically, patients with cholecystitis, 99% of them will be because gallstones are present, but the gallstones are present for a long time. What causes the problem? You have the gallstone sitting there, and then it causes some kind of an obstruction that then causes some stasis that then starts causing bacterial overgrowth, but potentially, and that triggers all this, the inflammatory chain reaction. Okay, so you're saying, sorry, there's the share thing. Right. So the features of the, so the first thing for cholecystitis is you want to check whether the patient has gallstones. Because as I said, 99% of patients with cholecystitis will be due to cholelithiasis in the first place, right? Then if you have gallstones, that doesn't automatically tell you that the patient's deranged liver function, for example, or the fever is due to cholecystitis. That's just one part of the problem, right? Because the gallstones are not new. Gallstones are chronic, subacute to chronic, and therefore they've been there forever. And you don't know whether that's actually causing the acute problem now. What what Nagesh said was about all the other signs, you know, the inflammatory fluid, etc. I'll come to that in the next slide. Those are actually called soft signs for cholecystitis. The hard signs, the two hard signs for cholecystitis are these two, which is, does the patient have gallstones? And along with the gallstones, does the patient have sonographic Murphy sign? Can anyone say what sonographic Murphy sign is?
Sorry, what was the question, Anna?
Sonographic Murphy sign.
So basically, if you use the curved ray probe onto the right upper quadrant, and if you're able to elicit the pain.
Correct. So
clinically, how you elicit the pain exactly the same.
Do you do this in a different avatar without the ultrasound? When you're examining patients, what do you look for? If you're worried about cholecystitis, what do you go and look for?
The tenderness, the right upper quadrant tenderness that we elicit.
So this sonographic Murphy sign is nothing but a fancy term to say the patient has pain when you're pressing. That's all. Okay. So when you press with your hand in the right upper quadrant, they will be tender. In this instance, what you do is you locate the gallbladder, you locate the fundus of the gallbladder, you know where exactly it is. And instead of using the hand, you use the probe to press on it. And it, lo and behold, an inflamed gallbladder will be associated with pain and tenderness. That's all. So the combination of these two is what you're looking for. This has an extremely high specificity for acute cholecystitis. And when I say the combination of these two, it is this plus this. Gallstones plus sonographic Murphy sign means cholecystitis. The other things are much, much softer signs. Why? Because they are far more operator dependent. Plus, there are so many other reasons why you have those other things. It is extremely common for you to make wrong measurements. If there's one problem I have with ultrasound, it is about measurements. Ultrasound is hopelessly unreliable for measurements. And when you're talking, and the smaller the margin of the measurement, the worse its reliability is. So I do not rely on thickening of the gallbladder wall. Second, pericholecystic fluid, again, it takes, it is something that that is more difficult to identify. Okay. Therefore, these are considered softer signs. If they're there, that's great. If they're not there, it doesn't matter. But if they are the only reason why, and if the patient does not have the sonographic Murphy sign or does not have gallstones, you cannot go and diagnose cholecystitis just because they have pericholecystic fluid or gallbladder wall thickening. Is that understood? So this is what you look for. The combination of these two is what you look for. This is softer. You don't really go and make any major management decision based on just the presence of the softer signs without the presence of both the hard signs. Okay. Any questions? Right. Biliary obstruction. What you look for in biliary obstruction in point of care ultrasound is specifically just about, about CBD dilation. You do not look for other ducts. Pancreatic duct is extremely difficult to identify because it's retroperitoneal and the anatomy is very challenging. Intrahepatic biliary dilation is something that happens only in the later stages. So you keep it simple. You want to know whether the CBD is dilated. Okay, right. Now, any questions before I move to how to identify gallstones? Right. Cholelithiasis, very easy. We see this all the time when you do echo. You have calcific valves, and the calcific valve will appear to be extremely bright, and you will have an acoustic shadowing posterior or deeper to the deeper to that calcification. So the combination, so this is important, the combination of a hyperechoic mass plus an acoustic shadowing deeper to it means there is a gallbladder stone. Okay. And sometimes the shadow is something that is extremely prominent. And just like how we say follow the money, here you follow the shadow and you find the stone. Okay. And what you have to do is do not, so if this is the long axis of the gallbladder, this is the short axis of the gallbladder, don't be happy with just these two. Always do a pan scan of the gallbladder. So once you get this, once you get the long axis, rotate the transducer. If the transducer is like this, rotate it fully to get the entire of, it will go from oblique and finally become circular. So you have to do this entire thing for the to look at every part of the gallbladder. Similarly, you then fan the gallbladder, fan it from cephalad to caudate or right shoulder to left hip, like this, in order to look at every part of the gallbladder from the neck of the gallbladder to the fundus of the gallbladder. And that's how, and you have to look for any missing stones, any stones that might have just gone and hid in a pocket somewhere, etc. Okay, so these are just some examples of stones. So again, if you follow the shadow, you will get to the stone. Okay, you have a clump of stones sitting there. If you follow the shadow, you get a clump of stones sitting all over. Okay, now the reason why you want this acoustic shadowing is because the differential diagnoses for stones include polyps or tumors, and the difference between polyps and tumors from gallbladder stones is that the polyps and tumors are tissue. Tissues do not have acoustic shadowing, so that's the most important. And also, polyps and tumors will not change in position, but that's not going to be something that we are going to do in critically ill patients. Okay, you're not going to ask the patient to sit and stand, etc., and see what happens. But therefore, the main difference is going to be about acoustic shadows. Now, when you have small stones, acoustic shadows are going to be more difficult. Okay, so small stones, that's one of the fallacies with point of care ultrasound, is that often with our technology, with the probes that we have, we might end up missing extremely small stones. Okay, what do you do if you find something but there's no acoustic shadowing? Okay, as I said, stones less than 4 millimeters. What you can do is you can increase the frequency of the probe and that will increase the acoustic artifacts, okay, including the shadowing. And then, of course, we talked about the other differentials, which is the polyps, etc. Okay. Any questions? Then sonographic Murphy sign, it's just a palpation of the fundus of the gallbladder, and you compress the fundus and you elicit tenderness. The most important thing here is do not press the rib of the patient, because that's going to hurt and that can also cause grimacing. Okay. Now, if the gallbladder fundus happens to be posterior to the ribs and you don't have a choice, then that's obviously going to be a fallacy. You might end up choosing a smaller probe, such as a convex phased array probe, a cardiac probe, in order to get in between the intercostal space. Okay. The positive response for a sonographic Murphy sign in the presence of cholecystitis is severe tenderness. The confounding factors are obviously some of our critically ill patients might be sedated or unconscious. But what I have seen is, even in patients who are encephalopathic, if you press and the patient actually truly has cholecystitis, you can often find that they grimace or sometimes they localize to the probe. Okay. It is highly unlikely for patients to have true cholecystitis and not have any response whatsoever. Okay. These are some other examples, okay, of what else could happen when you have cholecystitis. This is an example of chronic cholecystitis. You can see the various layers. There's a lot of thickening of the wall, pericholecystic fluid here, okay, and there's an impacted stone in the neck of the gallbladder with acoustic shadowing, okay. This is an example of sludge in the gallbladder. Sludge is nothing but, you must have all seen spontaneous echo contrast when you do TOEs in patients with atrial fibrillation and dilated atria. Sludge is actually more organized than SEC. SEC, because SEC happens in blood vessels, in a blood vessel containing cavity, it actually is swirling around. Sludge will actually settle down and it will have this mixed echogenicity. So this is the normal anechoic part of the gallbladder without the sludge, and this part here is the mixed echogenicity of the sludge. Okay. Then this is an example of a large stone. The stone is actually, this whole thing will, this is probably, it's a stone that's causing a big acoustic artifact with a lot of gallbladder wall thickening. Okay. Now, just coming back to this, the softer signs, I've talked about it to some extent, where thickening of the gallbladder, what you do, I told you before that I don't really worry too much about the transverse plane for the gallbladder, except for when I want to do measurement of the gallbladder, I want a standardized location. So if you have a long axis of the gallbladder and you're taking a measurement, you don't, ideally the measurement should be bang along the middle of the gallbladder. If you take it along one edge, automatically you're going to add a few millimeters, because the anterior and the posterior walls are going to intersect and you're going to add a few millimeters. So you want to avoid that. It is hard to identify the geographical midline of the gallbladder in the long axis. However, if you rotate the probe and make it a perfect circle, then you can just go anteriorly and measure it along the anterior edge of the gallbladder here. Okay. You should avoid the measurement posteriorly. And the reason for that is because a typical thing, when ultrasound passes through an anechoic space, you will have a posterior acoustic enhancement artifact, and therefore the posterior wall will always appear to be thicker than the anterior wall because of the additional enhancement artifact. Therefore, to avoid this, you do not measure it posteriorly. Okay. And the other thing, what you do is the measurement is outer edge to outer edge, just like how you measure it for the walls of the endocardium, etc., the myocardium. Transverse, in my opinion, is better than longitudinal, and don't do the posterior. And typical thickness is less than 2 millimeters. More than that can be thickened, remember that the margin is so, 2 millimeters is such a small measurement that often with the probes that we have, we will end up making errors. Okay, converting something from 2 to 4 millimeters is not at all a big deal. You can do that all the time. So that's why I don't like measurements. Okay, the differential diagnosis of thickened gallbladder wall in Dikila post. The anything that is going to cause inflammation or infection. So cholecystitis, obviously, but edema, transudative edema. So this is inflammatory edema, but all these things are transudative edema. And as far as the gallbladder is concerned, it doesn't care how the water gets in. If there is congestion, you're going to have that. Postprandially, you can sometimes appreciate a thickening of the gallbladder. And then there are a number of other causes, and I don't know the mechanism for these things. Okay, that's why I generally say the two things are stone plus Murphy plus tenderness or Murphy's sign. Okay, example of sludge. There are various variants for the gallbladder for cholecystitis. Acalculous cholecystitis is something that we infrequently see, but it's frequent enough that you'll see once or twice, once a year, once in 2 years or so. And essentially, this happens where this happens for some reason or the other. Systemic inflammation or infection can cause inflammation of the gallbladder or infection of the gallbladder. And the ultrasound findings will be exactly the same, except for the absence of a gallbladder stone. So you'll have severe tenderness, so severe sonographic Murphy sign, absence of acoustic shadowing, but very, very important, you will find a huge gallbladder. You'll have something that is 9 centimeters or so. Okay. And if you have a small gallbladder, I would not make this diagnosis. Okay. The wall might also be thickened. And I believe that sludge is invariably present. I have not looked at the primary papers, but this is from a textbook. Okay. The sonographic Murphy sign may be absent because of ICU sedation, but as I said to you, unless the patient is absolutely deeply comatose, there will be tenderness. Emphysematous cholecystitis is gas in the gallbladder wall. Any organism, various organisms, gram-negatives, Clostridium, etc., can cause that. And what you will have here is you will have, the air bronchograms that you see on lung ultrasound. You'll have the scattering of you have a combination of what should I say? The fluid. You'll have little B lines or C lines coming from the gallbladder wall, okay, causing various different artifacts, including speckling and reverberation. Okay, so it'll look like this. Yeah, this is exactly how this is a B line here. This is a B line here. Okay, so if you think about it, this is no different from the air bronchograms that we see, where you have an air fluid interface. Okay. These are various sources of confusion. Okay, now you have various acoustic artifacts coming from here. Now, sorry, what you have what we think is an acoustic shadow, but this is something that people can mistake for a gallbladder. But what this is actually is it's a loop of bowel. So the first part of the duodenum is extremely close. So it's very important for us to make sure that what you're seeing is within the liver parenchyma, and B, you have to get that exclamation mark sign. Okay, so the luck approach to doing CBD is for the common bile duct. The common bile duct is always anterior to the portal vein, and you locate it at the portal triad, which is where you do the exclamation mark sign, and you look for it in its short axis. Or if the patient does not have pancreatitis or bowel obstruction, which means you can actually see the pancreas, then you can identify it in the head of the pancreas, particularly if you have the probe facing transversely, and you can get it in its long axis. The technique at the portal triad is you get the usual longitudinal axis of the portal triad, which is the exclamation mark sign. and then the anechoic dot of the exclamation. So this is the gallbladder, this is the major lobar fissure, and this particular thing here, that's the portal vein. That's the actual dot of the exclamation mark. And the gallbladder, this common bile duct is seen like this, just anterior to the portal vein as two parallel strips like this. Okay, this is the CBD here. So this is your gallbladder. This is the major interlobar fissure. This is your portal vein. And this thing here is the exclamation mark. Okay, this thing here. Oh, sorry, this thing here is the CBD. Any questions? If you do a longitudinal view of the portal triad, then you'll have a different relationship. You'll have the portal vein being most posterior, and then just anterior to that, you will have the hepatic artery, and just anterior to that, you can have the short axis of the CBD. Okay. What is the definition of a dilated CBD? Unlike the gallbladder wall, for the CBD, we do inner dimension to inner dimension. Okay. So you measure here. Okay, that's number one. Number two, a very simple thing is that it must be the starting number of the patient's age. That's all, right? 1/10 of the patient's age or the starting number of the patient's age. Typically, if it's less than 5, it's normal. Okay, and if it's more than 9 or 10, more than 9 centimeters or so, on 8 centimeters, it is typically abnormal. Although in cholecystectomy patients, you can have a compensatory dilation of the CBD, which is physiological. And essentially, typically you look for, so if you have an 80-year-old, you can have it up to 8 millimeters or so. But so this is a nice thing to remember, the starting number of your age. Okay. When you're scanning for the CBD at the head of the pancreas, you keep the probe at the epigastrium. So this is your inferior, this is the sternum here. So you keep the probe somewhere in the epigastrium facing the 9 o'clock position, okay, perpendicular to the skin. And what you do is you'll try and locate so this is the splenic vein coming in its long axis. This is the superior mesenteric vein coming in its long axis, and they join together to form the portal vein. And the portal vein goes in the long axis of the probe. This is how the portal vein goes when it goes into the liver. And here, what you do is you just look at my hand now. You sweep the probe cephalad and caudad at somewhere near the splenoportal confluence, and you can then get the CBD in its cross section, and then you start rotating it to get it in its long axis. Color Doppler is something that you can do to get the to exclude blood-filled structures. Intrahepatic biliary dilation. Okay, what you do is you look for when is it dilated. If you have a railroad track sign, okay, which is you have multiple tracks like this, track marks like this, then this is normally the liver has you have the portal venous flow. Okay, that is completely normal. You should not be able to see the physiological intrahepatic ducts. If they are dilated, they will start getting dilated adjacent to the portal vein, and that causes the parallel railroad tracks, and both of them will have quite thick walls. Remember that the portal vein is quite a muscular vessel, unlike the IVC, unlike the systemic veins, and therefore you'll have bright walls, and the bile duct also has bright walls. So this is an example of intrahepatic biliary dilation. It'll look extremely similar to how it is on the CT scan. Okay, now just before I go to renal ultrasound, you can do a number of other things with abdominal ultrasound. You can look for liver cirrhosis, portal hypertension, you can look for portal vein dilation, and then you can actually scan the entire length and breadth of the liver to look for lacerations of the liver, spleen, etc. You can scan anywhere in the abdomen, along the abdominal wall, to look for the bowel, and I find that you can identify pneumoperitoneum. Pneumoperitoneum will have the classical A-line pattern of pneumothorax, so it's an extremely useful thing. Also, you can look for peritoneal sliding, just like pleural sliding, peritoneal sliding can be identified. And if the patient, if there is peritoneal sliding, essentially it rules out a pneumoperitoneum at that particular probe location. And secondly, it tells you that that particular segment of the gut that you are seeing is actually is having peristalsis, and therefore you can rule out mesenteric ischemia. Okay. There are so many things that you can do with abdominal ultrasound that it's very, very useful. We had about a few months ago, we had a patient where the surgeons were unsure. He came with severe constipation and bowel obstruction. We did an ultrasound and showed very clear pneumoperitoneum in the interval between the initial CT scan and subsequently. I won't say that was the only reason they took him to theater, but I'll probably pat myself on the back for showing them that and convincing them. I'd like to believe that that was one of the reasons. Okay. Any questions on this before I go to kidney ultrasound?
I have a question, Arvind. Is there any particular resource that's good for gut ultrasound, bowel ultrasound that you?
Liechtenstein's Liechtenstein's book on whole body ultrasound. Whole body ultrasound. Where is that? So
There's Liechtenstein, yeah.
It's written by Liechtenstein, and it's there's imaging.
That's all right. I can take a.
So this one here.
In the critically ill.
Full body ultrasound critically ill. I think you should be able to download that from your universities. It's pretty good. See, don't rely on textbooks or anything. You'll find that it's so intuitive. Just start scanning and you'll be amazed by the amount of information that you get out of it.
Yeah.
It is incredible. Because see, it just makes sense. You can, unlike cardiac ultrasound, where you have to work on your anatomy, here it's all inbuilt. So this is a very, very good book on various targets and so on. It's actually it's a very nice thing. It talks about adrenals. I'm not sure whether he also talks about the bowel, and you'll have to read it to see.
Okay. Thank you.
But it is with abdominal ultrasound, just don't be shy. Just start doing it. You'll identify all kinds of things. Okay. Renal ultrasound. Any other questions? Anyone? Okay. So renal ultrasound also extremely similar. Okay. The kidney is kidney shaped. It's bean shaped. It has the and you can actually see this when you're doing an ultrasound. The number of times you'll hit the kidney when you see the kidney when you're trying to do an apical 4-chamber view is so, it's I don't know whether you've actually seen. It's very, very common. Okay, it's an organ that is actually not very difficult to find, even though it's quite hidden posteriorly. Anyway, so it's a bean-shaped structure, and you have two big parts. You have the inner hilum, and you have the outer. So the hilum is this, and then you have the outer medulla, which is these things here. Okay. From physiology, you'll know 95% of the blood supply to the kidney goes to the outer cortex, and only about 5-6% of the blood flow goes to the medulla. And the medulla itself, or the hilum, is actually it is the drainage, the plumbing of the kidney, or the drainage of the kidney. So that's it. It takes all the urine and it puts it into the ureter. What that means is, if the plumbing is not obstructed, the medulla is going to be collapsed. The tubes are all going to be completely collapsed. Therefore, the inner part of the kidney, the inner hilum of the kidney, is going to be very densely packed structures with very little blood supply, which means that automatically they will be extremely hyperechoic. So this part of the kidney here is extremely hyperechoic. On the other hand, the surrounding part of the kidney, which is 95% of the kidney, or the cortex, because it is one of the richest blood supplies in the body, it'll be a tad hypoechoic compared to even the liver, because it has more blood supply than the liver. Okay, and therefore, as a proportion, it has far more blood supply compared to tissue, and therefore it is extremely hypoechoic. And this contrast is beautiful. You can immediately identify this beautiful contrast where you have a structure which this part is white, this part is almost black or dark gray, and you'll be able to identify it. Okay. The normal pelvic ileal system should not be seen because it is collapsed. The normal ureters are also less than 8 millimeters or so, and therefore they're also not really seen very well, except maybe by experts. Okay. The renal parenchyma, it's about 1 to 2 centimeters in thickness or so, about 1.8 centimeters. The hallmark, this is what you look for, the gray-white differentiation, like you see in the brain, you see the same things here as well. Around the kidney, you have the gerotas fascia and perinephric fat, and that will separate the kidney from the surrounding liver. So you will have that bright fascia separating it from the liver. So this thing here, that is the gerotas fascia. Okay. Right. So this is see how dark, if you can compare it with that of the liver. Okay. This is the liver here, this is the kidney, and you can see how dark the kidney is compared to the to the liver. Okay. These things here, they are the renal pyramids. Okay. The renal pyramids, 1 minute, please. The renal pyramids are essentially outpouchings. These are the things here, and that's where the urine will begin to be formed, and they will enter the renal pelvis. So you can actually identify that, and sometimes people can mistake that for hydronephrosis, but I'll tell you why it's not. Okay. What is the technique? You take an abdominal probe, typically 3.5 megahertz or so. You want something with a slightly deeper penetration because the kidney is a deep-seated structure. Okay. You go to and I've already told you that you have to start by getting in any ultrasound, you start by getting one structure that you can recognize, and then add an additional structure that you can recognize in order to get the anatomy. So if that's the patient, and this is the costal margin, okay. Now, if I will go somewhere in the flank, somewhere here, facing the 12 o'clock position, and typically I will actually start from superiorly where I get the liver. Okay, because the liver is the easiest organ in the abdomen to identify because of its size. Once you get the liver, then what you do is you go laterally to the flank, same probe orientation facing 12 o'clock, and then slowly slide the probe inferiorly, and lo and behold, you should be able to find the kidney. Okay, if you are not able to, you might not be in the correct antero-posterior plane. I don't know whether you can visualize that. You might either be too anterior or too posterior, and all you have to do is you just have to fan the probe anterior to posterior somewhere when you're missing the liver, when you're losing the liver as you're sliding inferiorly and you lose the liver on the screen. If you're still not able to find the kidney, just around that location, just start fanning anteriorly and posteriorly. And unless the patient has had a nephrectomy, you should be able to identify the liver. Okay, so typically when I say flank, I say right mid-axillary line, anterior axillary, posterior. It doesn't really matter actually, because if you have a reasonable window and if you don't have, say, bowel obstruction or something like that that has gas or pneumoperineum, then you can actually get a pretty decent shot from virtually anywhere from both anterior axillary all the way to posterior axillary. Okay, and I generally, as I said, identify the liver, etc., etc., etc. Okay, right. Then the left kidney will be slightly more difficult purely because the left kidney, the spleen is smaller. But once again, once you identify the spleen, then identify the splenorenal recess and you'll get that. So it's virtually the same thing. Okay. When you're doing the left kidney, you're more likely to get acoustic artifacts from the ribs because it's, you could potentially have a kidney that is just below the subcostal margin or even posterior to the ribs itself. And also, if you have a distended stomach, you can have a gas shadow from that. Similarly, the left cord, and in anybody, whether it's a left side or right side kidney, if you have bowel obstruction, then you'll have issues. Okay. So this is a snapshot. I actually don't know where I got it from. Unfortunately, I've not referenced it. But this is a snapshot about the normal parameters for the kidney. Typically, the length of the kidney is around 10 centimeters. Okay. The typical parenchymal thickness, which is the measurement from the renal surface to the sinus, is roughly about just more than a centimeter. You should have nice regular margins for the kidneys. Okay. The parenchymal echogenicity is typically either less than that or the same as that of the adjacent liver or the spleen. Okay. If you have a kidney that is actually denser on ultrasound, more echoic on ultrasound than the liver, then that might indicate a chronic kidney disease. Okay. The collecting system should not be seen at all in physiology. However, and that's why whenever you can see it well, that means that the patient is starting to have hydronephrosis, typically because of an obstructive uropathy. You can sometimes have it due to other reasons, which Drew might be able to say as the acute physician in the house. Calcifications, you can have stones. It's very, very difficult to identify renal stones compared to gallbladder stones, and I'll come to that in a minute. Okay. Renal masses are, again, depending on the echogenicity of the mass, renal masses may be difficult. If you have a cyst, example, simple cyst or polycystic kidney disease, etc., that's quite easy to identify because a cyst is black compared to that of the kidney. However, if you have white, if you have tissue masses, then you need CT or MRI. Okay, and forget about the Doppler. That's not part of the basic ultrasound. The main things that you want to know in renal tract ultrasound, just two questions. You want to know whether there is hydronephrosis. And second, if there is hydronephrosis, but the bladder is distended, it means that there is a bladder outlet obstruction, which will simply be resolved by inserting an indwelling catheter. Okay, so just these two questions. You don't have to complicate things. So is there evidence of hydronephrosis? And secondly, is there evidence of of a bladder outlet obstruction as a cause of the obstructive uropathy? With hydronephrosis, there are two main findings. You have a dilated pelvic calyceal system, and if it is chronic, you'll have a large kidney. Okay. The dilated pelvis is very easy to identify because the normal white hilum is replaced by a hypoechoic space with very prominent pyramids. There are various grades of hydronephrosis as seen here. Okay. Now, if you have very prominent pyramids, it could indicate mild hydronephrosis. And then as you keep going, this is severe hydroureter, hydropelvis, plus all the pelvic calyceal system becoming really dark and filled with urine. Okay. Typically I think this part you should be able to identify without any problems. Okay. So can anyone pick their mouse and show me the actual contours of the kidney in this one? I don't know whether I can see your mouse actually. Okay, that's fine. So this here is the kidney, and that should be white, and instead of that, it is quite black. And these outpouchings are the pyramids. So you have hydropelvis, okay, and here you have hydroureter as well. Okay, this is called splaying. It's looking like this. It's called splaying of the renal calyces. Again, very, all these are extreme examples, but when you see the patient, this is how it will be. Now, this is a renal stone, and you can see the calcific, you can see the acoustic shadowing. But the very big challenge you have is that posterior to kidney is actually white. And sorry, if the posterior to kidney, if you start having, sorry, if you have an obstruction and this part becomes black, okay, then the acoustic shadow, black on black, will not be visible. Therefore, it becomes difficult. So identifying the acoustic shadow from a renal stone may not always be possible. The stone itself, remember, this is white and the normal medulla is white, and therefore white on white may not be easy to discriminate. So therefore, seeing a kidney stone is actually very challenging. Therefore, we don't really think about it. Now, imaging the bladder. Any questions on the kidney? What I forgot to mention, once you do get the kidney in its long axis, just like with the gallbladder, just like with any structure, always fan completely in the long axis to get the anterior, sorry, from the anterior to the posterior portions of the kidney. And when I say anterior to posterior, you'll have to imagine remember that you are imaging coronally. It's like a coronal CT scan, okay? And what you are able to see, and this is anterior, this is posterior, and you want to fan all the way from anterior to posterior to look at every part of the kidney. After that, what you do is you rotate the probe counterclockwise and you scan, sorry, not counter, and you rotate it 90 degrees to get the short axis. And here you start scanning from superior to inferior, fanning all the way from the superior pole of the kidney to the hilum to the inferior pole of the kidney. And once again, you're looking for signs of hydronephrosis, cysts, etc. Okay, any questions on the kidney? Pyelonephritis, very subtle signs. You might be able to find stranding or perinephric fluid and all that, but the kidney itself, because it's deep, because it has a mixed echogenicity, because it has the white and white, etc., you will end up, it is not very simple. So just keep things simple, just look for hydronephrosis, and that's more than enough for us. Okay. As far as the bladder is concerned, what you do is you have to, if this is the pubic symphysis here, you keep the probe transverse here along the pubic symphysis, just superior to it. Okay, the probe facing 90 degree, the 9 o'clock position, because that's where the marker, the screen marker is going to be. So you preserve the anatomy on the screen. The left and right orientation on the screen is maintained if you keep that orientation. Okay, so you keep it transverse. And then what you do is you start tilting the probe superiorly to inferiorly. You start fanning the probe. Okay, and you might actually have to dig deep, which is you might have to go dig bit behind the symphysis pubis, sweep in a cephalocordad direction, and you're looking for a fluid-filled circle or a bag that's like a collapse like this. Okay, and it's an anechoic cavity bound by thin walls. Okay, once you get that in the transverse plane, you can also rotate it and get it in the longitudinal plane. And this is an estimated volume of the bladder, which is 3/4 of the volume of the length times height times width. If you have any automated software, then you can do that. I'll talk about the ureteric jets on color Doppler in a minute. Okay, but this is how a typical urinary bladder will look like. Okay, with the prostate posteriorly. Okay, so now what is the ureteric jet? At the trigone of the bladder, okay, if this is at the trigone of the bladder, you have the entry of the right ureter. You have the entry of the right ureter and the left ureter. If you reduce the scale, the color Doppler, if you put color Doppler and reduce the scale, you could potentially identify the flow of urine coming from the ureter into the bladder. Okay, and if you see it, it's a very cool, it's a goosebumps kind of thing. And in this instance, and the red and blue don't make any difference. It depends on how your probe is orientated to as far as the jet is concerned. In this instance, the probe is the flow is coming towards the flow is coming towards the probe, but doesn't really matter. So that this particular thing here is coming from the left ureter. This is coming from the right ureter. Okay. Now I don't, I said it's very cool to look at, but if you do not have this, if you do not have flow, it doesn't mean anything, because the patient might be having severe AKI. And if the volume of urine that they're producing, if they're oligoanuric, then you'll be waiting there for ages. You'll be there for 6 hours and you might not get a drop of urine. Okay. So it's like palpating for bowel sounds in the ICU fellowship exam. I tell my trainees never to do that, because if you don't have bowel sounds, you're going to be stuck there. Okay. So this is some, but if you do get an image of this, then take it. It's beautiful. Okay. So just going back to what you're looking for signs of hydronephrosis, which is this, and urinary bladder distension. And if you have a huge distended bladder and you can estimate the volume, then it means that the patient requires that to be decompressed either by a urinary catheter or by an SPC or whatever.